Good afternoon, ladies and gentlemen, and thank you very much for this opportunity to describe a little bit of what Liverpool has been doing in the COVID outbreak. Liverpool is leading on many research studies in COVID, but we're just going to simply focus on some of the outputs of the ISRIC study, and which have been incredibly well supported by the Health Protection Research Unit. And we've been working in partnership with Public Health England very closely. The other universities involved are Edinburgh, Imperial College and Oxford. We are funded by the NIHR and UKRI. Next slide, please. Next slide, please. Next slide, please. So we're going to introduce the ISRIC Coronavirus Clinical Characterization Consortium and the protocol, a quick review of the major outputs, which include describing risk factors for severe COVID in children and then in adults. Introduce the ISRIC 4C prognostic mortality score, which has been published now and is now being used in Australia, parts of India, Harvard are starting to use it. And then a summary of some of our outputs. Next slide, please. This is an overview of the current reach of the International Severe Acute Respiratory and Emerging Infections Consortium. The aim is to prevent illness and deaths from infectious diseases outbreaks. Launched by Jeremy Farrar in 2011, now covers 132 countries and 50 networks. The UK is but one of the 50 networks. Next slide, please. Using these protocols that are harmonized across the globe, we are able to gather data on outbreaks and then compare the data because the case report forms are harmonized. They have been used in the UK to study MERS, monkeypox. We missed the 2 cases of Ebola in 2014 that were imported, but we did do test activations in 2016 for community-acquired pneumonia, and then picked up 4 cases of MERS and monkeypox in 2018. Because of these activations, the protocol was well known by the high-level isolation units, but less well known by the district general hospitals. And consequently, it was quite a challenge to speed at the start of this year in the COVID response. And that's where the Health Protection Research Unit really came into its own, because it had that backbone of staff that could quickly step up and transfer to supporting a study such as this. I have to say we've now recruited 88,000 patients into the study, and we've got biological samples from 2,500 of these patients. Next slide, please. So the first important finding from our study was to show the very distinct patterns of diseases between men and women with COVID disease. And you can see from this graph, which shows on the left-hand side the vertical axis age, and on the horizontal axis case fatality. You can say that it's not simply a relationship that's linear with age. In fact, it's quite different between the sexes, and it is not a simple relationship. And this has been very important for developing the prognostic scores that we'll talk about later on. Next slide, please. We were also able to identify both the function of age, but also the more subtle relationships between comorbid disease, such as cardiac disease, lung disease, kidney disease, diabetes, which comes into its own on ethnicity sub-analysis, but interestingly, obesity. And in wave 1, we saw a very strong relationship between obesity and poor outcome. The same relationship has not been observed so strongly in wave 2. And there certainly is a different case mix of patients coming through now in wave 2. Next slide, please. Here we look at the data with ethnicity added. The challenge here is that because we use harmonized protocols across the globe, we choose to use the WHO ethnicity characteristics, which differ substantially from those of the Office of National Statistics in the UK. And this has led to some problems with the UK publishing houses, who are less inclined to use this data set. But nonetheless, it has allowed global harmonization and allowed us to look at this across our data sets. And here we can see that the pronounced signal of excess mortality in people of South Asian ethnicity and heritage. Next slide, please. We looked at this issue of ethnicity in some detail. We actually tried 4 or 5 different analyses, standard multivariate logistic regression. We did a Cox regression, logistic regression. We did propensity match score analysis, and then eventually settled on a DAG analysis. All analyses do agree in the UK data that South Asian ethnicity is associated with increased mortality. But when we do our very best to adjust for deprivation and for underlying comorbidities, we still have a large unexplained effect size. So basically, using the best adjustments we can show that comorbidities such as diabetes account for about 18% of the effect, but a large amount of the effect we could not identify. Subsequent analysis by the Office of National Statistics has shown that some of that difference can be explained by occupation, but nonetheless, either we're not very good at measuring multiple deprivations, or there's something else going on here that remains to explain the excess mortality in South Asian people, and it could well be to do with exposure within the community. Thank you. Next slide, please. Risk factors for children has been a great interest, and particularly topical with the return of children to school. We published this data in the British Medical Journal. Our data set now considers 2/3 of admissions across England, Scotland and Wales, and we only found 651 children in our study. To put that into context, that is only 1% of hospital admissions are children under the age of 19 years old. 6 of the children died, and all of these children had profound comorbidities. We are aware of 2 other children that have subsequently died, but these children were not enrolled in our study because the sites that were enrolling at the time were not submitting data to our study. So we believe there to have been around about 8 children that died in first wave. Putting that into perspective, there are around about 16 million children in the UK, and therefore we did conclude that severe COVID-19 disease is very rare in children. We did identify comorbidities that are associated with critical care admission, and these are the ones that one would expect, being prematurity and congenital cardiac disease, but also there was a signal for obesity, mirroring what we had seen in adults. Next slide, please. The risk stratification that is possible with this data set is quite remarkable. We were able to do this analysis. The analysis, I should say, was led by Professor Ewan Harrison and his team in Edinburgh. They took the data from wave 1 and took the first half of the wave, the up curve, if you like, identified 335,000 people in whom the mortality was around about 32%. And they used that to develop a training model. They also used an artificial intelligence model that included 41 variables, but there was no significant difference between the 41 variable model and the utility of the 8 variable model. That then went into a validation data set using the down curve of the first wave, which was a further 22,000 cases, and the mortality in that group was around about 30%. So having done a temporal validation, a sensitivity analysis was then done on a geographical split, on a north-south split, and that was a further validation step. So therefore the mortality score allows you to fairly accurately predict mortality based on front door presentation using 8 characteristics. These are age, sex, comorbidities, respiratory rate, peripheral oxygen saturation, level of consciousness, urea, and C-reactive protein. This is not an app. This is simply a numeric count up. Next slide, please. And you can see that with the benefit of perhaps paper and pen, if you can't count up to 21, it's simply a case of adding up score values against the criteria such as changing age, sex, comorbidities, coming up with a score, and then you run your score value along the x-axis, the horizontal axis, to come up with a score value, then read up to the curve and then move to the left to get your probability of death. It's really a very simple score. There's an example, there's an animation version that you can look at on the website, but this can be done in full PPE without need for electronics or an app. You just need to count up to 21, look at a paper chart, run your finger up, and you can get a feel for the probability of death. Next slide, please. Here we see on the panel A the distribution of scores across our data set, and you can see it's a nice distribution. We have observed versus predicted mortality in set B, slide B, the middle panel showing the fit, and then in slide C we have a comparison of the 4C mortality score against other commonly used scores such as CURB 65. And so this has this appears to be quite a useful tool going forward. We don't see it as being used as a decision tool, more of a decision aid, and it should help provide reassurance on which patients can safely be sent home because they're at very low risk of dying, and those patients who may need to have a closer look and may need escalated care into higher dependency areas because of high risk. Next slide, please.
Callum, you've got 1 minute remaining.
Thank you. That's all I need. So in summary, this is our summary slide. The public health research study that we've been running and we set up in 2011 has attracted just over £10 million worth of funding throughout the first and start of the second wave. We've used that money to set up outbreak laboratories in Glasgow and Liverpool in order to provide dispersed resilience. We've got our 88,000 cases enrolled. So far, we've got 18 publications, 10 with an impact factor greater than 20. The data is provided twice weekly to SAGE. We've provided 100 data and material shares so far to other collaborators. We also identified the outbreak of hospital-acquired COVID using this data set. We've identified the doubling of the length of stay if you get coincident influenza. And we've provided material to support the live vaccine challenge study that was announced on press release today by Imperial College. The virus that's going into that study is most likely to have come from Isaric's work. Next slide, please. That's us blowing our trumpet about the publications that we've produced. Next slide, please. Key publications that you can click on if you want to look at the data in more detail. Next slide, please. Funding statement, thanks to the NIHR and Department of Health. Next slide, please. And our acknowledgements. We had 3,000 frontline NHS clinical and research staff involved in collecting this data. Without them, this would not have been possible. Thank you very much.
That's fantastic, Callum. An amazing accomplishment from Isaric and the many people involved in that organisation, and great foresight to actually set it up in the first place. I remember the early discussions going back about 8 or 9 years ago for that. So it's done a brilliant job. The questions come in. So you had those that graph of the relationship between case fatality rate and a certain biochemical physical entity within each patient. So putting that together, what do you think the mechanism is behind the CFR increase with patients who are obese?
It's a really good question. Obesity confers other comorbidities which we may not have measured very well. Obesity is also associated with the pro-inflammatory state, and we do know that one of the aspects of COVID disease is a pro-inflammatory state. So I suspect it's a mixture of comorbidities and a hyper-inflammatory prothrombotic state is associated with poor outcome. But that's the kind of work that Kenny Bailey and colleagues in Edinburgh and other sites will be taking forward into the laboratory using this data material. Thank you very much.